Hello and welcome to the Functionally Enlightened podcast with Dr. Sharon Sarita. We interview well-respected medical and functional practitioners, as well as patients who have overcome disabling chronic conditions, such as dysautonomia, and reclaimed their health. These enlightened guests provide helpful tips on managing chronic pain and illnesses, using a combination of traditional and whole-body healing modalities. If you're interested in natural healing and quality of life improvement, you're in the right place. Thank you for listening to today's episode.
Hello, everyone. Welcome again to the Functionally Enlightened podcast. Today's guest is Tom Swales, who's a true game changer in the world of rehab and performance. With over 20 years of experience as a physiotherapist and a strength coach, Tom's earned a reputation for blending innovation with practicality, always a good thing. He's the founder of the Advanced Movement Therapist AMT certification, a groundbreaking program that equips clinicians, physical therapists, and strength coaches to go beyond pain management and to deliver transformative, performance-driven outcomes. But Tom's story is more than just accolades, right? He's got a lot of professional accolades, but it's deeply personal as well, because he went through his own life-threatening health crisis, and I'm going to ask him to share a little bit about that in just a moment. But his perspective on healing and performance has shifted profoundly as a result. So the pivotal experience ignited his mission to uncover root causes of pain, not just address one specific area of the body. And so he's empowering both patients and professionals to achieve real lasting breakthroughs. So Tom, again, thank you so much for joining us today. Let's dive right in.
Sounds good. Let's do this.
All right. So can you tell us or expand a little bit about the health crisis that you went through and how you got into this more functional approach?
Yeah. So last June, 2023, I had toxic shock syndrome, where it hospitalized me for 5 weeks. I had cardiomyopathy. I had liver failure, heart failure, kidney failure, rhabdomyolysis, a whole list of things, basically the whole body shutting down. They thought I was going to lose limbs. They thought I was going to be on dialysis for the rest of my life. I went in at 220 pounds and I came out at 170. So I lost 50 pounds while I was in the hospital. I had to learn how to do everything again. I could not. I went from being 100% independent, everyone relying on me to help them, to me having to rely on everybody to do the simplest things, which was a very humbling experience. And I have a greater appreciation for any function that I have that I can do independently, aside from before, doing gymnastics and soccer and snowboard and like all the stuff. And then I couldn't walk. I couldn't get up out of bed without help. I couldn't go to the bathroom. So you lose all your dignity when you're in that situation, but at the same time, you're very grateful for all of those around you who are stepping up to not just help me, but help my family, look after them, look after the business. So it was an eye-opening experience, and it put a different perspective on, what is priority in life, and putting family first and friends, and then everything else is kind of to the side. But I learned that the insurance policy of looking after my health for the last 45 years paid off, because multiple doctors came in to tell me, because I asked one of the doctors, I was like, well, what were my odds? They're like, oh, less than 20%. I said, oh, I was sick. They're like, you are super sick. And a few of them shared with me, 5 of us went in that summer with septic shock. And I was one of 5 that survived, and I had less stuff going on. So I didn't know, in the whole process, I never thought I was going to die. I was just like, I'm super sick. I'll get past this. I never believed like I wouldn't get through it, which I think belief has a tremendous impact on our abilities, as well as just being ignorant to the fact of, just defying odds.
Right. 100%. Your story definitely resonates with me and with most of our audience, because it's similar. Some people do have chronic illness that, over time it progresses, and then they have more and more disability. But there are so many people who've gone through like a traumatic episode, whether it be even something like a vaccine injury that has taken them from being fully functioning
Yeah.
to pretty much bed bound. And that's the case that I'm seeing now. So that transition that you have, you could be running 3 miles the day before it happens,
Yeah.
and like you said, fully functioning, and then
Yeah.
be completely dependent on the
Yeah. Oh, yeah.
support. So you did also mention the nervous system, and that's something that has been a harder journey for myself, like
Yeah.
understanding the role. So how do you incorporate the nervous system in your rehab work and with their performance strategies too? Because I know you work with like a whole variety of, very functional and high fitness
Yeah.
groups, and then you also work with people struggling with chronic pain.
Yeah. So I use the once we understand the primary role of the nervous system, it's survival of the individual, survival of the species. So you break it down into that. And then we look at, well, what are the two branches of the nervous system? Well, you have your sympathetic and parasympathetic, right? Like it branches off from there. When we look at movement and we look at motor output, when we look at mobility, when things are well organized and the nervous system feels safe and calm and relaxed, power goes up, muscles contract more effectively, our mobility goes, it improves. All of a sudden we can touch our toes because we applied an input to the body, and the nervous system said, oh, I like this. So all of a sudden it unlocks something. When we see something or hear something negative, when we feel something that we don't like, the nervous system doesn't approve, or the nervous system just doesn't feel safe, it locks up because it protects. So when we look at the nervous system, we're using it as a feedback loop for effectiveness. So often, whenever we're assessing anybody, I want to see, can you bend forward? Can you back bend? Can you stand on one leg? We look at the system first. I want to see how is the body as a system working and moving? Is there any asymmetries? And then we start whittling it down into kind of, well, this area looks a little bit off. Let's go investigate this. Once we start figuring out kind of those linchpins that are disorganizing the structure and setting off the nervous system into protection mode, then we can start to reorganize it. We start to, I'm going to say, unlock movement capacity because we applied something that the nervous system said, oh, I like that. That feels good. All of a sudden I'm more aware of that body part. And all of a sudden the shoulder releases, or all of a sudden they can touch their toes, or they can single leg balance. So it did something to reorganize the nervous system. And we look at the nervous system as a form of feedback to know if we're effective. Because oftentimes clinicians can get stuck in, patient comes in, wow, my shoulder's really tight. Okay, great. I'm going to go in and I'm going to needle the pec and I'm going to go release this and I'm going to minute this. And they didn't check their work. I was like, well, how do you know if that was effective? Right? You didn't look at anything from a systems perspective to know if that was truly effective. Or they didn't complement it. All of a sudden, it moves better, but they didn't complement it with new movement strategies to lock it in. So anytime we apply an input, manual therapy, modalities, whatever it is, you're essentially changing how the body feels, and it's going to change how it responds to the external environment and how it moves. But if you don't reinforce it with new movement strategies and other muscles to take over, it's going to come back, which is why, we get treatment and then 48 hours, you're like, it came back. Well, that's a good business strategy, but it's a horrible treatment strategy. Right. People just don't get better with that.
Right.
So that's how we look at the nervous system. It goes deeper than that, but from just a surface level, understanding that movement is output and anything input will affect output. And it can be a form of just checking your work and making sure you're on the right path.
Now, Tom, I like that you're addressing it in that route, but what are the kind of signals that you get from a client or a patient that tell you what you're doing is working, or that the nervous system really didn't like it? Like, how do they know?
So one, their breathing will tell you, their body language, right? Even just the first part of every interaction is conversation. If I'm using words that are a little bit scary, degenerative disc disease, the body is going to lock up. The body is going to kind of protect itself. Oh, I don't like those words because they're negative. Even though we use them for diagnosis, they're not really helpful for the patient because they just hear these negative inputs. Look at the breathing. If they start to breathe into their shoulders, I know their nervous system's shifting in the wrong direction. But if we can use language and I can get them to, yeah, we found these things, but here's the good stuff. Yes, we'll get past this. And we start changing their beliefs. Now we can start changing their abilities. So all of a sudden, just using words, I can all of a sudden start to see, oh, they're starting to calm down. Again, something as simple as stand up, can you touch your toes? Even if we don't do anything to the backside, if I get somebody to stick their fingers in there underneath their rib cage and just kind of massage the diaphragm or breathe into that, all of a sudden they can touch their toes. Why? Because maybe that skeletal muscle was a little bit pinned down and it released tension in their lower back. At the end of the day, I don't really know exactly, but if it changed their output, then maybe we're on the right track to making change.
Okay. And forgive my ignorance, but is that level of flexibility always the desired case, or do you have some clients that never quite can reach the toes and never can
Almost everybody can do it. Almost everybody can do it. Yeah. We all did it. We all did it at one point in our life. We wouldn't be standing if we couldn't, right? So, but it's, unless they have some anatomical restrictions where it's stopping them, most of the time the tight muscles are toned because the nervous system's just not using the right movement strategy or muscle strategy to perform the task. So again, they've associated, well, I've had 20 years of chronic low back pain, so they keep everything tight to protect. But the back pain by now is, the old injury is healed, but they haven't learned to move out of that strategy. So now they're causing these secondary problems of compression. Now they have more disc degeneration, they have more arthritis because of the compressive forces that they've held onto. But once we get people to feel where their spine is, or maybe we need to mobilize some nerves on the backside because the nerves are a little bit sticky and they're not sliding through the tissues as well as they should be. All of a sudden now the body feels different and they learn to let go. So to answer your question, is it necessary for people to touch their toes? Maybe, maybe not, but it's good to have that capacity, because if I need to bend over and pick up a shoe and I hit my end range and I try and pull out of that, that's where an injury potentially happens, right?
Okay,
because
yeah.
I don't have that buffer of range of motion that I can move in and out of safely, and I'm not strong there.
Mm-hmm.
So that's why we strength train, because, is it necessary to lift 400 pounds? No, but if I need to pick up somebody, my child, and run, it's so much easier.
Yeah.
Right. Sure. I've built up that capacity that hopefully I never have to use this in my life. But if I do have to use it in an emergency, it's not a problem.
Right. So
right?
let's use the type of clients I see, for example. They are very limited in mobility. They've been restricted for a long time.
Yep.
And so I work with people who have suffered from implant illness, primarily either like a hip replacement. Now hernia mesh is what brought me into this space, but they've had multiple abdominal or hip surgeries. So now it's kind of like they've gone through physical therapy, but they've only gotten to certain range of motion. They've not nowhere near return to functional living. So
Sure.
what are your suggestions? Like, how do you approach clients who have maybe 3 years out from this initial physical therapy?
Yeah. So we have to look at, the hernia is torn tissue and now it's depressurized. So you have this inequality of a pressurized system, which is the kind of pelvic cavity or the abdominal cavity, depending on where the hernia is. So if we've got too much pressure in that area, we have to start asking, well, why is there so much pressure in that area, and why did we blow out that tissue? What's not working around it? Quite often when I see inguinal hernias, people can't extend their hips. Their glutes aren't firing up like they're supposed to. They have stiff ankles, and they're running on stiff ankles where they can't get into proper dorsiflexion. So they have to rotate the hip or extend the back, and they give up their pelvic stability to propel themselves during gait. Now you do that enough times, over a lifetime, and you will cause micro tears in tissues. Those tissues get overloaded because those forces have no place else to go. So if we look at physics, physics tells us energy moves to the area of least resistance. If I'm walking and my ankle dorsiflexion isn't sufficient, I don't have adequate propulsion or connectivity to the ground from the foot, my glute isn't turning on, my hip just can't rotate into the socket effectively. And if I can't control rotation forces through my trunk, well, those forces can accumulate into the hip, into those anterior abdominal tissues. So now we have a tear because we're overstretching things. This happens a lot with hockey players. They get groin injuries because they're flexed over and then they're rotating in one direction, right? And then they go skating. But when I evaluate them, a lot of them can't extend their hip when they're out of their skates. Their glutes just don't work back here. So they've overstretched all the abdominal muscles because of their position and because of their rotation that they're doing. And they've gotten long and weak. So then they start tearing the abdominal muscles or the groin muscles. So it becomes a weak area because the backside isn't moving or there's not enough control in other places.
And this can be rehabbed over about how long does it take to prevent injury? And then for people who've already suffered, with a hernia and have had to have repairs, like if you could talk us through how you would work with them.
Yeah. So if we get somebody new off surgery, early exercises, they're laying supine, they're making sure that they can diaphragmatic breathe. Can they contract their pelvic floor? Can they posterior pelvic tilt? Can they activate their glutes in an isometric way? Like we're doing everything, we're turning everything on around it, but not pressurize the system. So we want to teach all of this kind of low level reflex stabilization to come on so that it starts taking pressure off of that area or that incision area. Once there's enough scar tissue, then we start to mobilize that scar tissue and start to organize it. So this is where we work with the fascial system. And when we're working with scars, we like to work with the scars because collagen just kind of places itself haphazardly. It's plug in the hole. Until there's forces that are coming across that scar tissue, it won't organize. When appropriate forces are coming, then those fibers, those collagen fibers, they start to line up with the tissues that they're filling in for. But what we also want to work with, and this is, we teach our clients how to do this, they simply just press on the scar area, the incision area, and they move in 3 planes. They go up, down, left, right, rotation. So I ask them, I'm like, okay, which way does it want to go? Does it want to go up or down? Oh, it wants to go down. Does it want to go left or right? Oh, it wants to go left. Which way does it want to rotate? Oh, it wants to go counterclockwise. Great. Now hold it there. So they sit there and they wait for the fascia to kind of start to unravel because you're working with the body and the body will tell you where it wants to go. If we assume that, oh, the tissue's not moving in this direction, we have to force it. How do you know? Right? And this is where I'll play with movement testing is if I'm not quite sure of, hey, what direction does this want to go? I'll just move the scar in a direction and I'll have them do an active straight leg raise. If the active straight leg raise feels less effort, the nervous system said it likes that. If it feels heavier, oh, maybe we don't go that direction. So I'm asking the nervous system, what do you like? Which direction do you want me to do? And I will also do that when I see, if I see rib flares, I'm like, oh, we need to mobilize those ribs. But I'll have the patient lay on the table, just actively lift their leg. I ask them, does that feel harder, easier? Remember how heavy that feels. And then I apply a pressure, and then I'll ask them again, have them lift it. Does it feel harder, easier? No difference. If they say easier, okay, great. The nervous system's saying we can touch that. If it feels harder, nervous system's saying, yeah, we're not going there yet. So I hate guessing because you look at a body and like, oh, there's so many things I can go at. Yeah, but how do you know where to start? So this is where I go back to the neurology and the nervous system, and I ask the body, what do you want? Do you like this? Yes or no? Because it's a go, no go system. Right? It's either, yes, I like this. No, I don't. But then there's also, it feels the same. Okay, great. It's not relevant. We can treat it, but maybe it's not going to have the impact that we're looking for. So we keep scanning around to find that kind of primary linchpin to see, oh, here's an area that it really wants us to work on. So we're going to work on this. And then we'll go back to the other area.
Okay. And so that's kind of the path of least resistance, the way you said, right, which is the opposite of what we're told in like conventional practices. We're told you're going to feel discomfort, you're going to feel the pain, so you got to push through it.
That comes in later when there's old scar tissue.
Okay.
When, someone's just like, yeah, it's stiff, right? But there's no pain. If there's no pain, yeah, we can dig on that. Okay. We need to friction that. We need to kind of really strip it. But if there's pain, if tissues are still modeling or they're still healing, do we really want to beat the crap out of it and cause more inflammation? No, it's already inflamed. Why would we do that? So work with it, align it. And then once there's enough scar tissue and they're moving and it's more stiffness, not pain, okay, great. Now go direct. So you have these direct and indirect techniques, but it depends on what phase that patient's in. If they're in a lot of pain, do I really want to be digging on those pain points? Like, it's not going to make them happy. I mean, we'll get an endorphin release and they'll kind of have this, analgesic effect, but it's very temporary. And sometimes they rebound and they get worse.
Right.
So I like working with the body, especially in the beginning and especially when there's pain, before I start kind of forcing it in directions it needs to go.
Okay. And so the scar tissue, here's another misconception that we have in this surgery world, where if you're having a defect like Ehlers-Danlos syndrome, for instance, and you already know there's a collagen disorder going
Right.
on.
Yep.
So you have a surgery and they tell you now that scar tissue is the only thing that's holding you together. So there's this
Right.
fear
Yep.
where you don't want to remodel the scar tissue. You don't want to break up the adhesions. How can
Sure.
you clarify that for people, like the understanding that it's okay to work through the scar tissue?
Yeah. I mean, this is where I use that indirect technique to work with the body, right? And show them how to do it themselves. Because if they're not comfortable with touch, like, oh, I'm afraid that you might push too hard. Okay, great. I will show you how to do this. You can do this to yourself. You can feel how much pressure you want to put. And if you're moving the tissue, it's going to have some form of an effect. It might not be as quick as if I do it, but it's still going to get you to where you want to go.
Mm-hmm. Absolutely. So going off of that, I know there's also people who are unable to move their limbs, like their legs. And so I know it makes it a lot more difficult to evaluate their strength, their mobility.
Sure.
So what are the things that they can do? Even I'm not sure if you have like online consultations as well, but maybe if they reach out to you or they want to learn how they can begin this process of trying to recover core strength.
A lot of it has to do with again, like we try and go at how we developed, meaning we started in these spine supported positions, spine suspended, spine stacked. So babies, we learn they're on their back and they're on their stomach a lot. They learn kind of that proprioception. The spine is supported so that they can move the limbs. Once they get proficient with that position, then all of a sudden the nervous system says, oh, you know what? Maybe we can press up into a quadruped position. We can now suspend that spine and we can manage those shearing forces of gravity through it a little bit more effectively. And then when they start crawling or they start kind of shifting their weight, now they're creating kind of these torques going through the spine. And then the nervous system says, well, if we can manage this okay, maybe we start moving those limbs. And then once it manages that, then we go up into stack. So we just go back down into some of the primary programming and primary positions when we first learn to move with gravity. So if that's in a crook lying position, that's where we like to start a lot of people is just laying on their back, put one hand on your stomach, one hand on your chest. Okay, can you breathe into there? Great. And then we start cueing them and getting them to feel certain muscles to come on. We can even get their feet engaged in that position. So if their feet are flat on the floor, legs are bent, well, okay, press your forefoot, press your toes into the ground. And now we can start to feel the glutes lifting up off the ground a little bit. So we're going to use pain as a guide, but we're also going to test them and see what can you do. Mm-hmm. And if we're getting into pain, okay, great. We've gone too far in a range or we've gone too difficult in an exercise. There's no harm in trying as long as we're being cognizant of what forces are we applying to the body and, what kind of success can we get the patient? Because somebody with a hernia, I'm not going to have them squat. That doesn't make any sense, but I might get them to bridge. Because it's working a lot of the same muscles, but at least they're in this more stable spine position and it feels a little bit safer and there's less forces coming through it, or there's less pressure that they need to use to try and stabilize their back.
Yeah, that makes perfect sense. And I'm thinking when I first started with my physical therapist, first they were like doing arm and leg rolls and like recumbent bike, things like that. But it was causing a lot of pain for my
Mm,
situation. I have
yeah.
abdominal wall denervation, and
Yep.
there seems to be people who have diastasis recti, which
Mhm.
we kind of um, discussed just briefly before
Yep.
recording, but um, they if they have a surgical repair and
Yep.
if they don't go to an abdominal wall specialist, they might still have mesh
Yep.
implanted between the muscle layers. And
Yep.
there is where they have some nerve damage that's taken place. Like
Sure.
in that, for myself, it's in the left flank. So
Yep.
I absolutely, that has thinned out completely. You can see it
Mhm.
on an MRI. It's paper thin. There is no muscle.
Right.
And so when we go and we approach physical therapy,
Hmm.
again, the leg mobility is very limited, but
Sure.
I do recall doing the bridge position like that.
Yep.
So can you tell us or share with us a little bit more, like what other types of exercises would we be able to do? And, if we want to work with our physical therapist, because not too many are
Hmm.
as educated in this particular case, but
Sure.
how could we help guide that kind of process of recovery?
Ooh, well, I mean, a lot of it has to do with education on the physical therapist side. Um, you can present information to them. Clients come to me, oh, can I get acupuncture? I've had that here done. Okay, well, how do we know that that's appropriate? Really, it comes down to the assessment and how well you assess, not just the dysfunctional area, but the whole body. What can the person do? What can't they do? And we work within the confines of what they can do. It's a tricky question because not every therapist is going to have the same training or the same perspective. And that's okay sometimes, because if everybody thought and did the same, we would have limited solutions to lots of problems. But it's really, if you're not getting results with the therapist, it's either put the onus back on the therapist to find more solutions rather than do the same thing,
Mhm.
or find another therapist and get a second opinion. That's all I can say. Right?
It
Because
makes sense, yeah.
yeah, I mean, we should be lifelong learners, and if we're not eager to change what we do sometimes, to evolve, to like gather knowledge and see if it works in our framework, in our paradigm, or even just break that paradigm and do something different, then we're not doing our jobs as clinicians, because we should be excited to go learn something new. Getting stuck doing the same thing over and over is boring, and I've seen it. People get stuck in their ways. Well, I've been doing this for the last 20 years, so I'm going to keep doing it till retirement. Well, then retire now. Like, it's, don't get stuck in your ways thinking that it's the way. One of my mentors, he's 70 and he is constantly taking courses. It's amazing, and he loves it. Like,
Hmm.
he gets more to, every time you take a course, you get more excited to do this thing again, because now you have more knowledge and you have more tools to help people solve problems. So coming back to your question, maybe encouraging your current physical therapist, maybe you should take some courses in this, or else I need to find another therapist.
Yeah, that could work.
I don't know how to answer that question, because the onus is on the therapist, and if they're not going to find solutions, well, then they need to refer you to somebody who has the solutions for you.
Yeah, yeah,
Right?
just like with all medical.
It's just saying I don't know, but I will find you somebody who does.
Yeah.
But then that even builds the relationship with, you, the client. If I say, what, I don't have the best answer for this, but I know somebody who does, well, at least I help them find the solution to their problem. Right? It's not like, oh, you're gone forever. Like, they'll come back, but I'm also going to communicate. And I've created a connection with another therapist. Be like, hey, I can't figure this out. Can you have a look at this person?
Hmm.
And then they'll communicate back to me. Great. Now we can work together.
Right, right. Yeah, the collaborative effort
Yeah.
is really what makes a difference sometimes, especially for those like really difficult cases where
Yeah.
there's multiple pieces. So that being said, let's switch gears a little bit to clients that are with conditions that are affecting the autonomic nervous system, like dysautonomia, and
Yep.
they're dealing with vertigo or
Yep.
orthostatic hypotension and these kinds of things. So a lot of the time, the focus wasn't on optimized movement, but
Mhm.
now that's like pivotal for my practice. That's like next to proper nutrition, it's
Yep.
optimizing movement.
Yeah.
However, I'm not a physical therapist, so I can't direct the movement.
Sure.
I can refer out and I
Yep.
definitely provide resources. But for this type of client, I can imagine you probably are doing the supine positions a lot. And then how is the progression with that particular type of client?
Yeah. So I'll like to see, can we work on some rolling patterns, right? Can they kind of segmentally stabilize? If it's too much twist, okay, great. We'll modify that. We'll go into little tuck positions, but I want to know if they um, segmentally stabilize their spine? Can they dissociate the spine? Because the spine's not supposed to be rigid.
Mm.
It's supposed to be stacked, but then it should be able to bend and twist and do all those nice natural things. We don't want clients to stay locked up forever, because then that just it doesn't, it's not healthy for the spine. Let's just call it that. Okay. It will cause degenerative issues and more wear and tear, but it'll also cause a lot of fear. And if they can't move the spine, the organs inside aren't moving as well either. So now they're going to have digestive issues. They're going to have pelvic floor issues. They're going to have all kinds of stability issues because they're using this one strategy, which is bracing. And it's effective if you're picking up something heavy, but it's not effective just to move around in the world when you're unloaded. It's
Mhm.
exhausting. So we can go up from the supine, we go into a quadruped, so on all fours. Can they move in position in that? Then we get them into some kneeling positions. Can you get up into a kneeling position, at least into a spine stack? Can you sit on the floor? What positions can you sit on the floor, right? Can you do a shin box? Can you do a V sit? Can you long sit? So getting them into these sitting positions, maybe eliminate the lower body and it's just pelvic up. Can you manage that? Okay, great. Maybe we can do some pushing and pulling while we're sitting on the floor. Let's get some bands out by increasing abdominal pressure and increasing the force in the upper extremity. Well, they have to use their core muscles a little bit more now, as opposed to just holding themselves upright. Now we get into those kneeling positions, either tall kneel or half kneel. Can you go into these transition positions? If they can manage that, then we get into standing. So we go through kind of all these transitions of different spine positions in relation to gravity. Can you manage it? Yes or no? Did your breathing change? Are you having pain? And are you using the right muscles to get the job done? And if there's a no to any of those three, we go back down and we do a little bit more work in that lower phase. And there's nothing wrong with that, right? But at least we have some kind of spectrum in which we can progress people either from this lower position. And sometimes people are like, this is too easy. Great. We'll move up into the next phase. Mm. But at least we have some kind of, like I said, spectrum to move from or regress them if we need to. And even if they get tired, say they're successful in the standing and they start to fatigue pretty quickly because their nervous system's starting to shut down. Okay, great. Let's go to the quadruped and get more work done there. So it's almost like a little drop set. Okay. There's no problem with that. And then days where they're feeling really good, you got to spend more time up here. Days where you're feeling crummy, we're going to spend some more time down here, but they can still get work done. Yeah. It's just, they're going to move along that movement spectrum.
Right, right. And thanks for hitting on that, because a lot of times, again, we start feeling that the fatigue, like, and it's beyond fatigue that you can explain, because we feel like we need to go lie down and literally can't move another muscle. But as you mentioned, sometimes we are too quick to make the decision that we can't do even the floor exercises. So I like that you gave examples of things that could be done in the case that the standing is not working.
Yeah, so. Exactly. There's always work to be done. When I came home, even when I was at the hospital, the physios who were great, and I knew them all. So that was awkward. But they were great. And they're like, well, what do you want to do? I was like, just put a mat on the floor and I'll roll around for 40 minutes, because my thinking was, well, I'm going to develop the strength from my center first before I start strengthening my limbs, because I need my spine to be strong in order to help me sit upright and then go do my squats and walking. So I'd literally roll around, I'd do dead bugs and I'd roll patterns and I'd do bridging, whatever I could. It was exhausting. And then they would get me up and they're like, okay, let's go to the bar and we'll do some squats and then we'll go try some stairs and then we'll get you back to bed. Okay, great. But just work can be done regardless of what level of conditioning you are. And a lot of the training when I got home, that was it. I was on the ground. I would just do ground transitions because that's all I had the energy to do. I didn't have a lot of energy to walk. I had a walker. I couldn't squat. Like I couldn't do any of the stuff in standing, but I could get work done on the ground. So, we learned that's where we first learned to move as babies when we first came into this world. But you develop that center strength, and then we develop out. So it's like this top down, center out development.
Yeah. Yeah.
So I just took that principle and just applied it to myself. And that's how, I progress and approach everybody. Even some of my high level athletes, they can't roll to one side. I was like, well, no wonder you got groin issues. No wonder your hamstrings are blowing up, because you've lost this fundamental rolling pattern, which is a single leg balance, which is also a pivot. And then all of a sudden we connect their rolling patterns, and all of a sudden their squat doesn't hurt anymore. Great. Because they lost some kind of control in their center axis, and their nervous system was creating these pain signals or these tight areas, trying to protect him, trying to compensate.
Yeah. Yeah. I think
So,
that's the case with even myself. I did not approach any type of personal training until maybe 2 years. Well, I'm going to say in the reverse order, 3 years after my last surgery.
oh, wow.
So mostly it was um, like manual work. I did a lot of physical therapy, but it was not me doing the motion really.
Sure.
They were
Yeah.
very minimal. And that was more, I think, the fear response and
Sure.
just not wanting to reherniate, not wanting to
Yep.
break the diastasis or rip the diastasis again.
Yeah, for sure.
But with that, I know there's people that also struggle with maintaining progress after they get a session. So for in your experience, what are some things that they can do, or do you instruct them on how to continue what they learn in shop to home?
Oh yeah, they get homework. They get emails. They get videos. Even if it's something as simple as, well, I don't have time. I'm like, well, do you have time to do 10 breaths? If they're breathing, if breathing's kind of like the number one thing that we need to kind of control and manage their stress levels, because even when you diaphragmatic breathe, it's putting pressure on that cylinder. So it is reflexively turning on some of those inner core muscles. And all I'd have them do, okay, fine, every hour, you're going to set an alarm, and you're going to put one hand on your chest, one hand on your belly. You're going to do 10 belly breaths. That's it. And then you move on with your day. Oh, well, that feels pretty good. Oh, you got more energy now. Okay, great. Now we're going to go onto the floor. You're going to do some glute bridges. You're going to do some rolling. Are you going to do some, like, it's finding and implementing little bits of exercises through the day, so that it's not like they have to be, oh, I have to go and do a 30-minute workout now. No, you can do a couple of 60-second workouts.
Right.
And you do that 10 times in a day. Well, you've got 100 reps under your belt. So it doesn't matter if they have to do it all in one bout. If you're getting the volume and the reps and the practice through the day, the body actually responds better to that than one bout of exercise.
Okay. That makes me feel better, because sometimes I am glued to a computer, and I every 45 minutes I'll get up and do a couple, two sets of 10 squats or something, or I'll walk around for a couple. So, and in my head I'm saying I didn't get my workout in, but there's still the movement. So that's awesome.
Yeah.
And you kind of mentioned it, I guess, with the nervous system response. I know that many people are now doing studies on heart rate variability and, just trying to control or trying to stimulate the vagus nerve, right? So actually, there's a PhD student who's recruiting people now to participate in that study. They have to have a formal diagnosis of POTS. And they would participate in this heart rate variability study. Are there any kind of biohacks that you use in your practice?
Ooh, well, we have PEMF, pulse electromagnetic field therapy.
Love it.
The machine we have, it's awesome. We use pulse centers. They're out of, I want to say, Atlanta. I think they're out of the States. I've heard about them for years, and then I got to play with one of the machines at the biohacking conference in Toronto one year, and it's amazing. Clients love it. We've had kids who had non-union fractures in their arms. They're supposed to be in a cast for 3 months. 2 weeks, they came to us after a month and a half, and in 2 weeks the bone healed.
Oh.
Like, it's a device that the FDA has approved for bone healing, non-union fractures, and osteoporosis, but it does so much at a cellular level.
Right.
It's amazing. Red light therapy laser is also one of our favorites. Not just like we have a stronger, diode one that we use for acute injuries, but we also have mats that we'll use that people can lay on. I mean, aside from, you know, plunging into the cold frozen lake, I mean, that's something I do.
Mhm.
I don't recommend it for everybody, but using cold therapy in any manner for increased stress saunas,
Yes.
I love it. We don't have one at our clinic, but what else do we use? We have, I mean, the traditional ultrasound. We use a lot of acupuncture. Acupuncture is a big modality that we use.
Very good.
Everybody has that, dry needling. But from the biohacks perspective,
I
I mean,
think
I
you
can only,
listed quite a few of them.
yeah, well, that's what we have at the clinic. And then I have my office is just littered with toys that drives my wife crazy. So I am open to try anything. You know, whether if it makes me feel better, as long, again, if it doesn't cause harm and it only costs me a few bucks, I'm like, I'll try it.
Yeah.
Right.
Yeah.
But I mean, coming back, it's a lot of it's behavior, it's a lot of fundamentals. Are you moving regularly? Are you getting enough sleep? Um, are you getting sunlight? Is your nutrition dialed in, and are you hydrated? I mean,
Hmm.
those are kind of the five tenets that I try and live by. And to me, that does 80% of the workload.
Right.
You know, the last 10, 20%, it's the supplements, it's, you know, all the little biohacks that, you know, they make you feel good and, you know, they work. But a lot of it is you can get a lot of the work done if you have a lot of the behavior fundamentals locked in.
Yeah. Yeah.
Yeah.
Yeah. I love that you capitalized on that again, Tom, because those foundational pillars are what the main focus is in functional
Mhm.
health. The
Yeah.
diet, the rest, the exercise,
Yeah.
stress reduction, super huge now, and
Yeah.
then supplementation for us for functional diagnostic nutrition.
Sure.
It's always an important piece, but it comes after all of these other
Yeah.
foundations. And
Yeah.
then when you talked about all of these modalities, I do love everything you listed.
Mhm.
Every single one. And then there's like the e-stim. What's your thoughts on e-stim?
So I'm a little bit so we'll do electrical stim on acupuncture. We have IFC TENS units. I used to be, and this is how we were trained, is you turn it up. You know, you tell the client, okay, let me know when you first feel it. Great. Let me know when it's strong but not painful. So you're turning it up to a threshold where it's just on the cusp of being uncomfortable.
Hmm.
Now, learning about how the nervous system responds and how we're these walking, talking batteries and all the cells communicate via electricity, a friend of mine, he's like, when you use microcurrent, it works kind of on a mitochondrial level. I said, okay. He's like, imagine, you know, he's like, I'd rather whisper to your nervous system than scream at it. And as soon as he said that, I'm like, you're right, because if you crank up high voltage on the skin, what does it send your nervous system into? Sympathetic. Well, healing doesn't happen there. So that makes no sense.
Mm-hmm.
So you're ramping up, you got these crazy muscle stim. And yeah, again, like you're going to get this endorphin release, you're stimulating sensory receptors, it's going to block pain, it's going to do all this stuff. From a healing perspective, I don't think it's doing anything. I think it's doing stuff for pain management in the moment, but it depends on what the goal is too. And we run at a DC current. We don't run on an alternating current. So the DC current that runs in our body, that, you know, we need to, if we can get access to low level DC currents, well, that's actually going to cause healing. But the alternating current is not natural to how our cells function. So from a healing perspective, I don't see much efficacy. From a pain management, yeah, it makes you feel better. So again, I don't know if that answers your question. It's a tool in the toolbox, and you use it for the right person at the right time for the right purpose.
Yeah, and the perspective you just shared about it sending or it creating that cortisol response and that being the
Yeah.
opposite of the rest and, rest and
Right.
digest or repair and recover. So
Yeah.
that's interesting. And I know to be respectful of your time, I just had another question, one more
Sure.
question. If you had to give a recommendation for something that works across the board for most of your clients,
Mhm.
or if you feel like it's the one thing that's needed to kind of make that shift happen, what would that be?
Ooh, the one thing, there's so many. I mean, I would say get your perspective on point. And what I mean by that is life is so busy that we can lose perspective of what's important. And we get caught in this rat race of, oh, I need to get this accomplished, I need to get this done, I need to do this for work. When if you just take a breath, take a moment to step back and realize, have I connected with my kids? Have I connected with my wife? Have I reached out to a friend that I haven't talked to in a while? It's gonna, that's, I mean, that's the point. That's the point of why we're here, is
Right.
create connection, make impact, whether it's in your home, whether it's local, whether it's global, whatever it is. And, wake up with purpose so that you keep wanting to wake up and do it again.
Yes, that is absolutely beautiful. I agree 100%. And so for people who want to reach out to you, learn more about your practice, your offerings, and all of the
Mm.
wonderful things that I don't know anyone else who has that many, what did I call them? Biohacks, within one
Oh.
office space. So that's
Yeah.
amazing. How can people reach out to you?
Yeah, so we're based in Barrie, Ontario, Canada. We're at 110 Bradford Street. So people who want to come in person, we have a staff of 25. We've got physiotherapy, chiro, massage, traditional Chinese medicine, acupuncture, movement coaches. So we've got a large team that we can work with. We work as a team, literally with our patients. We do offer virtual for those who can't make the trip. Again, everyone's trained with the advanced movement therapist certification, so everyone's on the same page on how to kind of look at the body as a system, using frameworks, and then utilizing the tools in their toolkit more effectively so that they can get to the root cause and solve people's problems more effectively. For education, it's amtcertified.ca. That's where the entire certification is on demand, so people can get started today if they'd like. My YouTube channel is Tommy Swales. There's lots of free stuff there. Instagram, swales.tom, and what else? Facebook is just Tom Swales. So there's lots of areas that I post online, free education, free resources, and then there's the certification for those who want to level up their assessment and treatment approaches.
All right, fantastic. We'll make sure to get all of that in the show notes, and also for our listeners, I know I briefly mentioned the study. If you want to participate in that POTS and HRV study, I'll get that information in the show notes too. I want to apologize for not having that at the top of the call, but that's something that, anything to do to benefit the research on dysautonomia is ultimately what this channel is all about, and practitioners like Tom Swales, who offers his insights and getting people up and moving again, and then all of the other lifestyle pieces that are fundamental. That's who we need to seek out when we're looking to restore our own health. So Tom, we appreciate you sharing all of your knowledge with us today.
Thanks for having me, Sharon.
All right, and we'll see you on the next one, everyone. Thanks for tuning in.